Good afternoon. I think we're going to go ahead and get started. People are kind of just filtering in now. So anyway, I'm David Chambers. I am one of the new pulmonary faculty. And for today's talk, I decided to kind of give an update on evaluation and management of pleural effusions. Now, this is generally going to be a very guideline-based talk, kind of going over the most recently published guidelines, particularly for the workup of pleural effusions, but then also for management of some special situations. I do not have any relevant conflicts of interest to disclose. So we're going to start out with a brief overview of the anatomy and physiology of the pleural space and the general pathophysiology of pleural effusions. We're going to move on to evaluation of unexplained pleural effusions, and then talk about management of recurrent malignant effusions and of empyema. And then we'll give a brief overview of management of refractory nonmalignant pleural effusions. All right, so starting out with the anatomy of the pleural space. So just a brief overview. There's two layers of the pleura. You have the parietal pleura, which covers the costal surface, the diaphragm, and the mediastinal surface, and then the visceral pleura, which covers the lung itself. And these two layers merge at the hilum of the lung. So the parietal pleura has a pretty significant surface area. And within all of this surface area, there really should only be about 10 milliliters of total fluid. So the pleural fluid itself arises from several places. You have the pleural capillaries, the interstitium, the intrathoracic lymphatics, and it can also arise from the peritoneal cavity through small diaphragmatic defects. And that becomes important in a few special types of transudative pathologies. Generally, should only produce about 0.1 milliliters per kilogram per hour. And the lymphatics can generally absorb about 0.28 milliliters per kilogram per hour. So as you can see, there's a pretty significant excess reabsorptive capacity of the pleura when compared to the normal physiologic pleural fluid production. So you have to have either a significant excess in pleural fluid production or a significant decrease in the reabsorptive capacity to develop any excess fluid in the lung. So any fluid in the pleural space in excess of what should be there suggests a very significant imbalance between these two. Pleural effusions can develop from either excess production or impairment in reabsorption. And in many pathologies, you actually get both. So as far as the normal properties, generally it's a very low protein fluid, should be alkaline, and then so can have immune cells, but those should mainly be macrophages, monocytes, and lymphocytes. So any neutrophil predominance in the pleural space is also very abnormal. So moving on to unexplained pleural effusions. So whenever you diagnose a pleural effusion, there's a general algorithm that you can go through to determine where the pleural fluid is coming from. And this algorithm is based on the 2010 British Thoracic Society guidelines, which are the most recent guidelines for workup of unexplained pleural effusions. Now, you'll note that they specify unilateral pleural effusions. Bilateral pleural effusions in general are caused by transitive causes unless you have something else that should suggest that there is an alternate explanation. So for instance, if someone's coming in with fever, pneumonia-like symptoms, or if someone has a history of known malignancy, then you can treat bilateral pleural effusions as though you have two unilateral effusions. But in general, if someone's clinical history is suggestive of transitive causes and you have bilateral pleural effusions, per BTS guidelines, you can treat them as having transitive effusions without necessarily having to sample the pleural effusion, the pleural fluid. So as you can see, the guideline is very dense, and I'm going to unpack this over the next few slides. So when we talk about workup of anything, we always start out with the history and physical. And there's a few really specific things that you should hone in on. Now, typically we get the history of, is there a history of pneumonia, a history of malignancy, and these are going to weigh into how we do our workup. But a few of the more specific things, you really should look for signs of possible pulmonary embolism. Pleural effusions are very common with pulmonary emboli, and in these cases they tend to be small, filling up less than 1/3 of the hemithorax. And the reason you want to have a high index of suspicion is that patients with pulmonary emboli who have an effusion, sampling the fluid's not really going to help you with the workup, and it's not really going to help the patient. Another big thing is medications. There's several medications listed here that are well known to be associated with pleural effusions. And then you also want to look for signs of causes of transitive effusion. So things like heart failure, liver failure, volume overload, renal failure. So the most important beginning part of the workup is a good PAN lateral chest x-ray. The lateral film can detect up to 50 milliliters of fluid. And again, if you have a history suggestive of transitive etiology with bilateral effusions, even if one is small and one is particularly large, you don't necessarily have to do a thoracentesis as part of their workup. So the next step, if you notice a unilateral pleural effusion, you're going to have to sample it, but prior to sampling, you should start with a pleural ultrasound. And there's a few things that you can get out of this. So the biggest thing is we know that real-time ultrasound guidance does improve the success rate of thoracentesis and decrease the complication rate. Now, when the typical X marks the spot technique that's been used, where you ultrasound, mark, and then do your thoracentesis, has been studied, you don't see the same benefit. However, a lot of times that has involved taking the patient to ultrasound, doing the ultrasound, marking them, moving them, and then doing the thoracentesis away from where you did the ultrasound after they've changed positions a few times. So it's the most practical way of doing it is take your ultrasound, do it immediately at the bedside with the patient positioned, ultrasound after you've marked them, and then proceed with your procedure. The other thing that pleural ultrasound can do, it's more sensitive than CT at detecting septations and increased echogenicity, which can suggest an inflamed or complex pleural space. Now, this is an example of a pleural ultrasound with a very small pleural effusion. I wanted to point out a few of the anatomic landmarks that you need to see on an ultrasound in order to be able to say there's a pleural effusion. So most important landmark is right here. This echogenic stripe is the diaphragm. And in this case, you can see the liver underneath the diaphragm. So you need to be able to identify the edge of the chest wall. You need to be able to identify the lung. So right here you see the visceral pleural stripe. And then you have to see your anechoic free space within. And this represents the effusion itself. So something like this, you may not be comfortable doing a thoracentesis on because this is a rather small effusion. But if there's a strong need to sample the fluid because you suspect a malignant effusion and it would affect staging, or you suspect a possible empyema, then even an effusion this size, it would be safe to get a sample of. So our typical laboratory analysis that you should get. So all effusions, the major things you need are protein, LDH, gram stain culture, and cytology. If you suspect a possible pleural space infection, then you should also separately draw a sample into an ABG syringe, evacuate all of the air, and then cap it. Because you do get changes in the apparent pleural fluid pH if you have any included air in the syringe, or if you have inadvertently drawn up some local anesthetic into the syringe as well. And then you should also draw extra fluid for cultures, and you should inoculate these cultures immediately at the bedside. So bring the blood culture bottles with you and immediately put about 8 to 10 cc's in each color. You do need at least 50 milliliters to be sent specifically for cytology. This appears to be the optimal amount for yield. In general, because of the need for molecular studies and PDL1 testing, any fluid that I have not sent for other laboratory tests, I will send for cytology. So I'll literally send the entire bag, even if I have 2 or 3 liters in the bag. Again, because it doesn't, over 50 milliliters, you don't improve the diagnostic yield. However, you need a good bulk of cells in your cell block for ancillary testing. Generally, we do send cell count. This tends to be less useful than many of your other tests, and the primary reason for this is that any long-standing effusion will become lymphocytic. So neutrophil predominance will typically suggest a more acute cause, but even pleural space infections, eventually, if you let them sit long enough, they can become lymphocytic. If the fluid appears bloody, go ahead and send a hematocrit. And then because you're going to need them for your Lights criteria, don't forget to send your serum protein and your and lactate dehydrogenase as well. So we all know Lights criteria. So it's been used since 1972. Basically, it's your ratio of pleural protein to serum protein, your pleural LDH to serum LDH, and then you look at your total pleural fluid LDH. So generally, these are very good. If Lights criteria tell you that it's a transudate, then that's good evidence that it is a transudate. The one issue with Lights criteria is that chronic diuretic therapy can also turn a transudative effusion into something that will look like an exudate by Lights criteria. So if you have a clinical situation where this might be the case, for instance, you have someone with chronic heart failure, chronic liver failure who's on long-term diuretic therapy, you can send a serum albumin and a pleural fluid albumin as well. And if the gradient between those two is greater than 1.2, then that's strongly suggestive that what you truly have is a transudate. Now, if the fusion is transudative, then you start with your workup for heart failure, portal hypertension, renal failure, and your treatment is going to be treating the end organ cause of the effusion. Okay, so if you get an exudate, then you do have to go into further workup. And the further workup is generally based on your common causes of exudative effusion. So your big three are malignancy, parapneumonic effusions, and pleural tuberculosis. So some of your less common causes, a lot of the time you're going to be able to get by history. So things like pulmonary embolism, autoimmune diseases, benign asbestos effusions. These you'll generally have a history that will suggest that these would be a possibility. And then if you get an exudative effusion with no evidence of malignancy and no evidence of a pleural space infection, then these you can be pretty confident that those are what's going on if you have the appropriate history. Now, the issue comes in when you get a non-diagnostic laboratory analysis. And here, if your history and physical don't point you to a particular diagnosis, this is where contrast-enhanced CT chest comes in. And in order to get a good picture of the pleural lining itself, you do really need the contrast. Things that you can see on this, you can see pleural enhancement that can suggest empyema, and a little bit later on we'll go over some of the signs that you see with pleural space infection. And then you can often see nodularity that can suggest areas of malignant pleural effusion and give you places to target for possible biopsy. Now, if after the CT you have nodularity of the pleura that would suggest a malignant pleural effusion, you are going to want to proceed to a biopsy. These you would ideally do CT guided. And just a little aside about blind pleural biopsy, typically should not be done unless you have a very strong reason to suspect pleural tuberculosis. Sensitivity of blind pleural biopsy for any other pathologies is less than 50%. So if you don't see anything on the CT that is a potential target for biopsy, you can repeat the cytology. Your initial cytology is going to be about 60% sensitive for malignancy. A second cytology adds about 29% to that. After that, you really don't get any benefit from doing further simple pleural fluid sampling. So if your repeat cytology is negative and you don't have a diagnosis, this is where you have to look into doing a procedure to get you direct visualization of the pleural space. Kind of the workhorse for this has been video-assisted thoracoscopic surgery. This is currently what we're doing here. Advantages are really you can get bigger biopsies of the pleura and you can more safely work in a more complex pleural space. You can get multiple tools into the pleural space, and if you see something in the lung itself that needs dealt with, you can deal with it as well. There's another procedure called medical thoracoscopy, which involves using a smaller camera done through a single port that is placed under moderate sedation and local anesthesia. Advantages to this, the biggest one is that for more frail patients, you're not exposing them to the risk of general anesthesia. The biggest disadvantage is that your biopsy sizes are smaller, and then if you do run into a complication, you have less ability to manage those. So in general, patient selection is important. If you have a patient that is at high risk for mechanical complications from the procedure, those are patients who really should go to VATS. And if you have a patient where your imaging has suggested significant complexity to the pleural space, those are also patients who really would be best served through a surgical approach. Once you've completed this workup, you have a diagnosis. I'm going to talk about a few special conditions that have specific guidelines for their pathology. So we'll start with malignant pleural effusions. So these are very common, 125,000 cases per year, cost of about $5 billion annually. Majority of patients will eventually develop resting dyspnea from malignant pleural effusions. And these do have a significant effect on prognosis. Life expectancy after diagnosis of malignant pleural effusion generally going to range within 4 to 7 months. So because of the burden of symptoms and the decreased lifespan from this, for palliating it, you really want therapies that will relieve dyspnea with as few interventions as possible. So your initial workhorse is generally going to be a therapeutic thoracentesis. And there's a few benefits that you get from starting out with thoracentesis. The biggest one is you can do it quickly. Doesn't require much procedural planning, and in highly symptomatic patients, you can get them immediate relief. The second thing is you establish whether or not draining the pleural effusion actually relieves their dyspnea. So quite frequently, patients with advanced cancer will be dyspneic for reasons other than their pleural effusions. And you also get patients who won't be particularly symptomatic with their pleural effusions. And so this part is based on guidelines recently published by the American Thoracic Society in 2018. So asymptomatic patients and patients whose symptoms are not relieved by drainage should not undergo further procedures. You're not going to do them any benefit evacuating the pleural space if it doesn't help them feel better. So the third benefit that you get from thoracentesis is you establish whether or not the lung completely re-expands after you drain the pleural space. And what this plays into is if the lung does completely re-expand, these are patients who, to whom you can offer basically a choice between a tunnel pleural catheter or pleurodesis. If the lung doesn't fully re-expand, then pleurodesis ceases to be an option. And so these are patients who would better be served by tunnel pleural catheter. And then the final thing you get from it is you establish time to recurrence of symptoms. 60% of patients are going to require a repeat procedure within 9 days of your initial thoracentesis. So options for palliation. Serial thoracentesis is a very common option that we use. And there's two settings in which it tends to be very helpful. The first is we get patients who are dealing with, they're in shock from having a diagnosis of metastatic malignancy, and they're not mentally in a place where they can commit to undergoing more advanced procedures. And so this can be a way of maintaining relief from their symptoms while they have time to process their diagnosis and weigh for themselves the risks and benefits of a lot of your more advanced palliative procedures. And then patients needing infrequent drainage often will benefit more from just coming in as needed for thoracentesis. And generally when I say infrequent drainage, I'm talking about patients needing drainage less than about once a month. So our other two options for reducing the need for further procedures, you have pleurodesis. So you either mechanically abrade the pleural space surgically, or you instill a sclerosing agent to scar the two layers of the pleura together. Key issues with pleurodesis, it does require the two layers of the pleura to be in apposition with each other. So if you do not have a completely re-expandable lung, pleurodesis is going to fail. It does require an inpatient stay for chest tube management. It is not 100% successful. In general, with talc, success rate in studies goes between 72 and 80%, depending on the study that's been done. The biggest advantage is if this is successful, then it's a one-and-done thing. Patient goes home, they don't have a catheter, they don't have to do any drainage, they don't have to get supplies, they go home, they're not symptomatic, and they don't have to worry about their effusion anymore. Our other option is the tunnel pleural catheter. So one of the key advantages to this that we run into a lot is that we can use it for patients whose lung doesn't expand all the way. A lot of these patients that we offer tunnel pleural catheter to, you've already done a thoracentesis. You know that evacuating what you safely can from the pleural space improves their dyspnea, but you're not going to be able to get the two layers of the pleura to oppose to one another. So this procedure, we can do it as outpatient, so it doesn't require a hospital stay. The issues are you do have to have ongoing management. They need good social support. They need to be able to take care of the catheter. And the reason for this is that there is a risk of both soft tissue and pleural space infection from these catheters. And while the risk of infection is low, it's not insignificant. Best studies that have been done suggest that the overall risk of infection is about 5%, and the risk of pleural space infection is about 2.5%. And so, like I said, low, but certainly not insignificant. So in comparing the two, there have been 5 randomized controlled trials that have directly compared these modalities. In general, there's no difference in the degree of symptom palliation. Of course, the median hospital stay is longer with pleurodesis. And because you do have failures of pleurodesis, on average, people require more pleural procedures afterwards. And like I said, the main driving force for that is people where the pleurodesis doesn't take. So there were more infectious complications with tunnel pleural catheters. Interestingly, on economic analysis from one of these trials, the Time 2 trial, there really wasn't a significant difference in cost across the study population. Now, when they did subgroup analysis looking at people who lived less than 14 weeks, those people actually had a lower cost from a tunnel pleural catheter. And what's really driving the cost there is the hospital stay after pleurodesis. So in general, the recent ATS guidelines essentially say if you've got a fully expandable lung, either manner is reasonable. So what I do is I have a discussion with patients and offer them both, talk about the risks and benefits of each one, because patients all have their own things that they prefer. So if you have someone who kind of has a poor functional status, not expected to live long, really doesn't want to have a stay in the hospital, these are patients who will tend to gravitate more towards the tunnel pleural catheter. People who don't like the idea of having to manage a catheter, who are predicted to survive for several months after the procedure, or people who have poor social support who really aren't going to be able to take care of the catheter, are going to have a higher risk of infection from the catheter, maybe aren't going to be able to get the supplies that they need. These are the people who may tend to gravitate more towards pleurodesis. So the writers of the guidelines didn't find any sufficient evidence to recommend one method of pleurodesis over another, installation versus talc poudrage surgically. So their guideline suggests that either one is acceptable. Complex pneumonic effusions and empyema. So pneumonic effusions occur in about 20 to 40% of patients who have pneumonia. And of those, about 5 to 10% of them will progress to complex pneumonic effusion or empyema. Of those that progress, you have about a 15% mortality rate. And 30% of these patients will end up needing surgical intervention for their pleural space. The biggest risk factor for this progression is a history of alcohol or IV drug abuse. When we talk about pleural space infection, we generally talk about 3 general phases that they go through. You have the exudative phase, which is where you have a sterile exudate without bacterial infection. And then that progresses to the fibrinopurulent phase, which is where you get bacterial translocation across the lung border into the pleural space, increased neutrophil activity, and then you really get an imbalance between procoagulant and anticoagulant activity. And then finally, you have the organizing phase, which is where you get scar tissue and pleural peel forming in the pleural space. So as far as initial things that should suggest an infected pleural space, you may see the fluid initially on your presentation chest x-ray. Of note, often if you've got a collapsed lung or a consolidated lung immediately adjacent to this fluid, that interface can be very difficult to see. So the x-ray can look like someone has a significant pleural effusion when in fact they simply have a consolidation. The good news is that ultrasound can very effectively help distinguish between fluid and consolidated lung. So any patient with a pneumonia that fails to improve over a few days of appropriate antibiotic therapy, you really should look for a potential concurrent pleural space infection. If you suspect a possible pleural space infection, then the 2010 British Thoracic Society guidelines suggest that these patients should all undergo a contrast-enhanced CT scan. So there are several things that you can see on a contrast-enhanced CT that can be particularly helpful for predicting empyema. They tend to have a lenticular shape. You can see enhancement of the pleura. You can see thickening of the parietal pleura. And when you have these things together, you can get what's called a split pleura sign. Other advantages of CT scan, they can reveal causes of pulmonary infection. In particular, you can see if they have a large mass in their airways that's obstructing the distal airways and causing a post-obstructive pneumonia. If you see things that suggest possible septic emboli, suggesting a seeding from endocarditis. And then CT, when it's contrast enhanced, can actually help you distinguish between a lung abscess and a complex pleural effusion. Ultrasonography, as discussed before, also very helpful. Can help you determine, do you actually have a pleural effusion? Can help you select an appropriate site for sampling pleural effusion. There's some evidence that ultrasound can help with prognostication as well. So a highly septated pleural space, very unlikely to resolve with chest tube drainage alone. So both the British Thoracic Society and American Association of Thoracic Surgery guidelines suggest that if you have more than 1 centimeter of fluid on a chest x-ray or 2 centimeters of fluid on the contrast CT, you should sample that pleural fluid. And again, don't forget your blood and your respiratory cultures as well. These can help identify a causative organism in settings where your pleural fluid cultures don't grow. So once you have diagnosed complex parapneumonic effusion or empyema, so generally agreed upon therapy, antibiotics always. Community acquired, you want a 3rd generation cephalosporin plus metronidazole, the reason being that these infections frequently have anaerobes that are extremely difficult to grow out in culture. Or you can choose an aminopenicillin with a beta-lactamase inhibitor, so ampicillin sulbactam. In a hospital-acquired infection, you also do have to cover for MRSA and Pseudomonas. You still have to cover for the anaerobes. So while the combination of vancomycin and piperacillin tazobactam or vancomycin and meropenem would be appropriate, the combination of vancomycin and cefepime would not be sufficient because cefepime does not have the anaerobe coverage. So of note, aminoglycosides do not penetrate the pleural space very well. They actually get inactivated in the acidic conditions of a complex parapneumonic effusion. And so they should not be used as your primary antibiotic in these cases. Nutrition support, always paramount. These people are in typically a highly inflamed state. They tend to develop significant cachexia. And then you have to think about whether or not you should drain the effusion with a more definitive manner, so a chest tube. Generally accepted indications, both the BTS and AATS guidelines would say if you get frank pus, you need to drain the pleural space. If you have a positive gram stain or culture, you need to drain the pleural space. If you have properly collected the pleural fluid pH and it's less than 7.2, again, that suggests a pleural space infection that's not going to resolve with antibiotics alone. So the AATS guidelines also recommend that you perform chest tube drainage if your glucose is less than 40, if the LDH is greater than 1,000, or if you see any evidence of loculation. So as far as surgery goes, some subtle guidelines between subtle difference between the BTS and AATS guidelines. So BTS would suggest that generally it's patients who have a persistent fluid collection and signs of sepsis after 5 to 7 days of antibiotic therapy and drainage. Whereas the AATS guidelines suggest failure to achieve complete drainage or failure of clinical improvement should prompt consideration of advanced therapy. It's never wrong to call your thoracic surgery colleagues to see if they feel that in this particular case a patient would warrant formal surgical decortication. Now, on review of the literature, both guidelines actually advise against routine use of intrapleural thrombolytics. However, so the BTS guidelines were actually written in 2010, and this was prior to the MIST-2 trial. The AATS guidelines are from 2017. When they look at the bulk of the evidence, they suggest that there is not a proven benefit to intrapleural thrombolytics. Now, I want to go a little bit over the MIST-2 trial and point out some specifics of it, because this is an ongoing area of controversy. So the MIST-2 trial, done in 2011, randomized 210 patients who had signs of systemic infection and either empyema, so frank pus in the pleural space, or complex pneumonic effusion. And the way they define that basically goes along with the BTS guidelines for who needs advanced pleural space drainage. All of them underwent antibiotic therapy and chest tube drainage, and there were 4 study groups that they were randomized to. There was either placebo, TPA alone, DNase alone, or combination of TPA plus DNase. These were dosed twice daily for 6 days. The dose was 10 milligrams of TPA and 5 milligrams of DNase. Interestingly, the primary endpoint that they chose was the change in area of hemithorax occupied by pleural opacity over a period of 7 days. A few secondary endpoints that warrant mention: surgical referral at 3 months and at 12 months, mortality at 3 months and at 12 months, volume of fluid drained, and resolution of inflammatory markers, including CRP, fever, and white blood cell count. So for the primary endpoint, they did prove a significant improvement, specifically in the combination group. So the groups that got either TPA alone or DNase alone did not show any significant improvement over placebo. They also noted fewer surgical referrals in the TPA plus DNase group compared to any of the other groups. Interestingly, even in the group that got placebo, their surgical referral was only 15%. In the TPA DNase group, it was 4%. They also noted lower white blood cell count and fewer incidences of fever at 7 days in the group that received the combination therapy compared to the other groups. There was not a significant difference in C-reactive protein. So they did a planned subgroup analysis and didn't note any difference in results among any of the subgroups that were analyzed. So kind of the takeaway from this is that in people receiving TPA and DNase, you do get improvement in the amount of pleural fluid that you clear out. You have more people where the signs of sepsis improve over about 7 days, and they did end up referring fewer people to surgery. Now, the biggest issue with this study is that they didn't really look at long-term outcomes. In particular, they didn't really look at the incidence of they didn't really specifically look at the incidence of fibrothorax in these patients. They didn't look at long-term functional status. And so these are the primary criticisms that the AATS working group had of this study. So in my general practice, I personally feel that a trial of thrombolytics is reasonable in these patients. If I have someone who has an overall otherwise good functional status, I think those are people where offering consideration of surgery is warranted. And if I have people where, looking at the pleural space with ultrasound, they've got thick septations, looks like they've got evidence of a pleural rind. It doesn't look like something that enzymes are going to be able to clear out. Those are also people that I feel that early surgical referral is advisable. And certainly, again, always something to discuss with your thoracic surgeons. So where the use of thrombolytics I feel is most helpful is in frail patients where you've talked with your thoracic surgeons. They really probably are not going to be able to tolerate surgery well. Okay, so finally, I do want to talk a little bit about refractory non-malignant effusions. So multiple common causes of these. We've all seen our patients with congestive heart failure, renal failure, cirrhosis. Some of your less common causes, chronic inflammatory pleuritis, persistent chylothorax. All of these, generally your first line treatment is aimed at the underlying condition. However, in a certain proportion of these patients, the effusions are going to be refractory to first line treatment. They're going to continue to recur at a rapid rate, and people will feel better for a few days after you drain the effusion, but then they'll be back in your office complaining of dyspnea. They'll be back in the ER complaining of dyspnea. So what can you do for these? A lot of the palliative options for effusions are not very good in these cases. So with serial thoracentesis, these effusions often will reaccumulate much more rapidly. I've had patients with hepatic hydrothorax where I was having to drain them every 2 to 4 days because of how rapidly they would recur. And each of these procedures really carries a risk of bleeding, infection, pneumothorax. Small for each particular procedure, but when you're doing multiple procedures over a period of a month, the risk adds up. Pleurodesis generally has a lower success rate than malignant effusions. Part of the issue with that being the fluid accumulates so rapidly that it can actually be hard to maintain apposition of the two layers of the pleural space. And then even when it's successful, these effusions can recur on the opposite side. There's reports of surgical repair of diaphragmatic leaks in hepatic hydrothorax patients. If you consider the kind of patients we're talking about, though, you're talking about patients with end-stage organ disease. And these are patients who generally are not good candidates for surgery in general. So recently, the tunneled pleural catheter has become more of an option for these patients. So multiple series in heart failure showing relief of dyspnea, reduction in heart failure-related hospitalizations. And then in liver and renal failure, you also have some small case series suggesting significant relief from tunneled pleural catheter patients, in these patients as well. Word of caution, though. Infection, particularly in hepatic hydrothorax, tends to be a greater risk. Overall, the patients that have been reported, about a 10% risk of empyema. In general, the likely explanation is that these are patients who, while they do have serious end organ disease, they do tend to live longer and have the catheter in place longer than patients with malignant pleural effusions. One important thing to note, though, is that in the one series that went over or that looked at specifically candidates for transplant, no one was disqualified for transplant because of catheter-related infections. So in general, my practice has been in patients who have these refractory non-malignant effusions. If they're requiring thoracentesis so frequently as to be impracticable, I'll offer them a tunnel pleural catheter. But again, careful evaluation of social status. Are they going to be able to take care of the catheter? And then careful discussion with the patient about the increased risk of infectious complications in this setting. So I'm going to finish up there.
Do you also always send for AFB and fungal cultures when sending cultures for the first time diagnostic?
I don't always. I would only send AFB cultures if I have a good reason to suspect pleural tuberculosis. Fungal cultures, fungal empyema is extremely rare, generally in immunosuppressed patients. And typically, the causative agent would be Candida in those settings, which will generally grow out on traditional cultures. AFB culture on the pleural fluid, its yield is low enough that if you strongly suspect pleural tuberculosis, it really shouldn't be your only investigation.
Sometimes with empyemas, you have multiple loculated areas instead of one that communicate. So would you treat those with individual drainage details, or would you more likely to send those straight to surgery?
I would be very likely, unless there's a strong reason to not consider surgery, I would call the surgeons on those cases.